Good evening. My name is R.J. Sealock from Baylor College of Medicine in Houston, Texas. I would like to thank the course organizers for the opportunity to discuss EUS-guided gallbladder intervention in high-risk patients. The objectives of the talk are to discuss EUS-guided gallbladder drainage, its technique, patient selection, and clinical outcomes. Laparoscopic cholecystectomy is the treatment of choice for symptomatic cholelithiasis or acute cholecystitis. Patients at higher surgical risk may require non-operative gallbladder drainage. Percutaneous transhepatic gallbladder drainage is endorsed by major societies and has long been used as the primary modality of non-operative gallbladder drainage. However, percutaneous transhepatic gallbladder drainage is associated with adverse events requiring reintervention in upwards of 66% of patients. And percutaneous drainage can be uncomfortable and affect quality of life, which is particularly important, particularly when used in patients with limited life expectancy. This is a cartoon of percutaneous transhepatic gallbladder drainage. An update to the Tokyo Guidelines on Cholecystitis in 2018 stated that endoscopic therapies for gallbladder drainage can be considered in high-risk patients. The two therapies that have been highlighted in this update include endoscopic transpapillary gallbladder drainage in the middle and endoscopic ultrasound-guided gallbladder drainage, which we will further discuss in this talk. What is the definition of a high-risk cholecystectomy patient? Well, it depends on who you ask or what you read. Based on recent randomized controlled trials comparing non-operative modalities of gallbladder drainage, they have defined high risk as age greater than 80, American Society of Anesthesiology score greater than or equal to 3, Charlson Comorbidity Index greater than 5. The Charlson Comorbidity Index predicts 10-year survival in patients with multiple comorbidities. When a score of 5 is reached, the estimated 10-year survival approaches 21%. Patients with higher rate of conversion to open cholecystectomy, given the degree of gallbladder inflammation, may be considered high risk. But honestly, the definition of high risk patient must be individualized and may ultimately be dependent on the surgeon evaluating the patient. A brief slide on endoscopic transpapillary gallbladder drainage. The pros of this non-operative gallbladder drainage include it is reasonable to consider in patients who are needing ERCP for alternative reasons, such as choledocholithiasis or concomitant common bile duct obstruction. The other benefit is that it does maintain gallbladder integrity and may theoretically improve the ability to do subsequent cholecystectomy. The cons of endoscopic transpapillary drainage include a lower technical success rate of 83%, which will be highlighted in subsequent slides, and durability of this drainage modality may be limited by stent patency. Commonly in this procedure, smaller caliber stents such as 5 French or 7 French are employed. And the ampulla must be accessible, which may be difficult in patients with malignancy of the head of the pancreas and resultant duodenal obstruction. Moving to EUS-guided gallbladder drainage, it was initially described in 2006 using a 3-step method in which the gallbladder was identified either by the transgastric or transduodenal approach. Using an access needle, the gallbladder was punctured, guide wire was advanced into the gallbladder lumen, and subsequent dilation of the tract was performed using a balloon dilating catheter. And then once the tract was dilated, pigtail stent can be advanced from the duodenal or gastric lumen into the gallbladder lumen. Limitations of this approach include multiple device exchanges, which with each exchange could potentially result in loss of access. Bile leakage and resultant peritonitis could develop. as a result of the inability of the two lumens, the gallbladder, to approximate each other. And the time spent in the procedure is also lengthened given the multiple device exchanges. What has revolutionized EUS-guided gallbladder drainage was the development of lumen-opposing metal stents. And experiences gained in the management of pancreatic fluid collections has basically opened the door to EUS-guided gallbladder drainage and its acceptance. The development of lumen-opposing metal stents has streamlined and improved the safety of EUS-guided gallbladder drainage. This is a video demonstrating EUS-guided lumen-opposing metal stent placement. Full disclosure, this is a pancreatic pseudocyst. For easier visualization, the stent catheter is advanced into the pseudocyst cavity using a pure cutting current. The stent catheter is then advanced further into the cavity, and the distal flange of the lumen-opposing metal stent is subsequently deployed within the cyst cavity. Once the distal flange is fully deployed, the stent catheter is then brought back to the wall of the cavity, thereby approximating the wall of the pseudocyst cavity or gallbladder to the wall of the bowel. And then under endoscopic guidance, the proximal flange is subsequently deployed within the stomach with prompt drainage of pseudocyst fluid. This video demonstrates the steps in EUS-guided gallbladder drainage performed by the endosonographer. In this video, we have Cal Patel, my friend and mentor, deploying a lumen-opposing metal stent in a porcine gallbladder model. The first step is the stent catheter is attached to the electrosurgical unit. The stent catheter is advanced to the wall of the duodenum, and using pure cut current, the catheter is advanced into the lumen of the gallbladder, taking care to avoid advancing it all the way to the posterior wall. A guide wire can be advanced through the stent catheter into the gallbladder lumen. In the event that stent maldeployment occurs, you still have access to the gallbladder lumen via a guide wire. Now, after appropriate visualization, the distal flange of the lumen-opposing metal stent is deployed within the lumen of the gallbladder, while gently advancing the stent catheter forward. This results in some loss of visualization of the gallbladder lumen. However, visualization is subsequently restored by gentle retraction of the stent catheter, which also brings the fully deployed distal flange to the wall of the gallbladder, as demonstrated here. And once the distal flange is fully approximated to the wall of the gallbladder, the proximal flange can be subsequently deployed. And the proximal flange is being deployed within the working channel of the echoendoscope. And to advance the proximal flange out of the working channel, gentle right torque is applied while also advancing the stent catheter in, which then fully pushes the proximal flange out of the scope into the lumen of the duodenum, and complete deployment is achieved. This is a demonstration and still images of the deployment of a lumen-opposing metal stent for EUS-guided gallbladder drainage. The gallbladder is identified either through transgastric or transduodenal approach. The gallbladder lumen can be punctured with a 19-gauge access needle, Contrast can be injected through the needle into the gallbladder lumen, distending the gallbladder a bit further and also identifying its anatomy on fluoroscopy. And once this has been obtained, the aforementioned steps of lumen opposing stent placement are performed. And then we can see purulent bilious fluid being drained into the wall of the stomach. If needed, one benefit of lumen opposing metal stents does allow direct visualization and intervention if warranted within the lumen of gallbladder. And this can take the shape of stone removal or lithotripsy within the lumen of gallbladder in the setting of stones, or the evaluation of malignancy. There have been 5 studies comparing the various means of gallbladder drainage, whether it's percutaneous, endoscopic, transpapillary, or EUS guided. These include 3 systematic reviews and 2 randomized controlled trials. I would like to highlight the study by Mohan, which was a systematic review comparing endoscopic transpapillary versus EUS versus percutaneous catheters. And what you can identify is the technical success of EUS guided and percutaneous drainage is higher compared to endoscopic transpapillary therapy. And the clinical success of EUS guided gallbladder drainage is higher when compared to transpapillary and percutaneous drainage. The study by Teo and al. Was a randomized controlled trial comparing EUS guided gallbladder drainage versus percutaneous. EUS guided drainage achieved similar technical and clinical success, but one of the striking things of this study was demonstrating that EUS guided gallbladder drainage resulted in fewer adverse events when patients were followed for a mean of 30 days, with EUS guided therapy resulting in adverse event rate of 12.8% and percutaneous drainage of 47.5%. Most of the adverse events in the percutaneous group were a result of catheter occlusion requiring replacement. Special populations in which more data are needed to evaluate the safety and efficacy of lumen opposing metal stent placement for EUS gallbladder drainage include cirrhotic patients, particularly those with ascites. Case reports have demonstrated this to be safe if the acidic fluid can be appropriately controlled. Other population is liver transplant patients, and it is currently unknown whether the placement of a lumen opposing metal stent into the gallbladder would result in more difficult or technically challenging transplant operations. Adverse events of EUS-guided gallbladder drainage include stent maldeployment, whether entirely within the gallbladder lumen, intraperitoneal, or within the lumen of the duodenum or stomach. Stent migration has also been reported, as demonstrated in these pictures here, where after a period of 60 days, the proximal flange of the lumen opposing metal stent can no longer be visualized. Other complications include bleeding with a rate of approximately 4.2%, biliary leaks, stent occlusion, and recurrent acute cholecystitis as a result of occlusion of the lumen of the stent, occurring up to 4.5% of patients. When comparing adverse events of percutaneous transhepatic gallbladder drainage versus EUS-guided gallbladder drainage, as highlighted in the Teo study, 30-day adverse events at 30 days were 47% in percutaneous drainage versus 13% in EUS-guided drainage. And at 1 year, adverse events were as high as 77% in percutaneous and 25% in EUS guided drainage. One of the big questions is whether patients who have undergone EUS guided gallbladder drainage can eventually have a cholecystectomy. Cholecystectomy post-EUS gallbladder drainage requires fistula closure to prevent enteral leakage. The retroperitoneal location of the duodenum may make fistula closure difficult. Small series have reported successful cholecystectomy rates with 9% conversion to open cholecystectomy. However, larger studies are needed to definitively answer this question. And what about EUS-guided gallbladder drainage training? As with many things in endoscopic training, it is a stepwise approach. The first step is being competent in endoscopic ultrasound, followed by fine needle aspiration or fine needle biopsy. And the next step would be becoming competent in EUS with cyst enterostomy for pseudocyst or walled-off necrosis, followed by formal didactic and hands-on education, which is specific for EUS-guided gallbladder drainage. What are the future directions of EUS-guided gallbladder drainage? Future studies are needed to identify the appropriate patients for this therapy. Additional studies are needed on the appropriate lumen-opposing metal stent size. Current lumen-opposing metal stents, luminal diameter can range from 8 millimeters all the way up to 20 millimeters. And longer-term studies evaluating the efficacy, safety, and adverse events of EUS-guided gallbladder drainage are definitely needed. And we need more data on cholecystectomy after EUS-guided gallbladder drainage, particularly if we hope to adopt this therapy to a much wider or diverse patient population. With that, I thank you for your attention and look forward to your questions.